Substance Abuse Subcommittee will hold a hearing. Today's date is April 5th, 2016. Roll call, please, Mr. Clerk.
Chairman Belanger.
Here.
Council Mercia.
Here.
Council Rock.
Here.
3 present.
Okay, thank you very much. On today's agenda, we have a presentation outlined for the City of Lowell's First Watch program and co-op program, both of which combat opiate addiction. I want to thank everybody for being here today. We have Christopher Dick from Trinity Ambulance, along with John Kelly from Trinity Ambulance, Kevin Garno, one of Lowell's finest in the police force and stationed downtown, been very helpful to us all. Superintendent William Taylor's on hand. Terry Downs from Middlesex Community College. Chief Jeff Winwood is here. I'm sorry, Lieutenant. Thank you very much. And Councilor Bill Samaras. So I think we'll start with the First Watch program, which has been very well received, John. And, we appreciate this is a cutting edge program that allows the City of Lowell to have real-time information on the addiction and how as frequent as overdoses happen, where they happen, when. And it's very, very valuable information. It will prove to be very valuable in this fight against addiction. So, John, I think I'll start with you. If you can begin the rollout, if you don't mind.
No, thank you, sir. So, I'm going to talk to you about First Watch. So, right off the bat, it's zero cost to the city. We pay the upfront and the monthly stuff. And even IT support, there really isn't for the city. There's an app from the app stores, and it's all web-based. So, again, you don't even have to type your IT support. And what First Watch does is it provides live access to our patient care data, and it'll help improve the situational awareness of the parties involved with the opiate struggles. So First Watch is used by about 300 agencies across the United States, like LA Fire has it, Miami-Dade, DC. And for the opiate specific, they've developed this trigger that we were the 9th to purchase back in November, and it's up to about 30. Every week they're getting more and more communities across the United States signing up for it. This First Watch isn't going to be the solution, but it's a tool in the toolbox that can help the chiefs and the public health agencies to as we try to cope with the opiate epidemic that's kind of on our communities. So for Lowell specifically, we think it help with the opiate overdoses. Tonight we'll talk briefly about kind of a needle pickup type thing too that can help the city, some help for the schools, and then Project Care and kind of the support for that. So basically, kind of give you a brief overview of the system, right? So the EMTs and the paramedics go take care of the patient. When they're done taking care of the patient, every ambulance has a laptop in it, so they'll do their patient care report right in the ambulance. And then as soon as the call is saved, that's really when First Watch kind of kicks in. And every 3 minutes, it reads through our database of calls, okay? And it does if-then statements, okay? So it's looking, if this event happens, then do this. So for the opiates specifically, it's looking for 6 words. It's looking for 6 things. So it's in the narrative of the story of the call. It's looking to see if the paramedics or the EMTs wrote heroin, opiate, Narcan, and Naloxone. Okay, and if any of those words are there, then it fires the trigger, okay? If the chief complaint was selected of an opiate overdose or heroin overdose, it fires the trigger as well. And if you look on, I didn't number the pages, I apologize, for the opiates, it says for opiates. If you look at that little thing, that's a picture of my phone, and that's, if you're an authorized user, that's what you would see on your phone if you choose to have it on your phone, okay? With HIPAA regulations, there's limitations to what we're allowed to share, and who we can share it with. We have to be very cognizant of the patient's rights and what information we're able to share, whether it would be with law enforcement or public health. So for the next page, it shows you an example of a redacted patient care report, okay? So this is from First Watch. This is their HIPAA compliance, so there's no address, there's no patient name, date of birth. If you look to the right, you can kind of see the area of where the overdose happened, but you can't see exactly where it happened. You don't know what house it happened in. Okay, and if you read through the report, you can get kind of the Glasgow Coma Scale, you can get kind of some brief chief complaint type stuff, but you don't know enough about the patient where you can figure out who it was. And again, from HIPAA concerns, that's really the legal way to do it. We do have the availability to provide a full patient care report, but those are going to be kind of the one-offs, and we'll have to work with our HIPAA attorneys we've brought online and with the city to figure out who needs access to that to make sure that we're all in compliance with the HIPAA regulations. Okay? And so that's just the one individual opiate overdose, right, on that page. That's the one. But when you step back for a minute, and look at the next page, there's a map, and it shows kind of a 72-hour look at the city of where the overdoses are happening. And we really think that's where the real value would be, was you'd be able to see where things are happening today, okay? You know, the reports we provide are you know, a month old. This can tell you what's happening now, okay? So we've got it set it up at 72 hours after talking with Kevin, Officer Gano, excuse me. And, you know, he was saying that they do 4 on, 2 off, and we kind of came up with the 72-hour being a good window. That's fully customizable. We can change that if the city wants something different, okay? But that's kind of the default we did for that one. So we started in 2012, 13, 14, the city would call kind of annually and would give a number of opiate overdoses we did. Starting last January, at the request of the city manager and the council, we started doing it monthly, right? So that'll continue. We wanted to speed that up even more. So this seemed to be the next evolution, was how do we tell you guys about them faster? So the monthly reports will still stay like they are now, but what we're able to do with this product is about an hour after each call, the city would know that it was an opiate overdose, and they would be able to get the information that quickly, okay? Also, it'll help with town lines. So we provide service for 4 towns down here in a row. So if someone's on Westford Street and they overdose, and they fall to the left, they could be in Chelmsford, fall to the right, they're in Lowell. If they fall in Chelmsford, Lowell would never know what would happen, right? Lowell Public Health probably would never know that event happened. Lowell Police wouldn't know what happened. With this, we're able to provide across those city lines, if the city managers all agree to it. If, let's say, Chelmsford didn't want to do that, we could pull Chelmsford out and their data would stay isolated. But we think, you know, everybody says this is not a Lowell issue, this is an all of our issue, and this can kind of help provide a little bit situational awareness, kind of regionally more than just here in our community. We also think it can really help discover new areas of use. You know, we look at the numbers every month where the overdoses are happening. You know, if let's say, Lower Belvedere, right, doesn't have very many. If suddenly they start having 5 or 6 or 7 of them, this product, before we build up the muscle memory that, hey, something's going on, you could visually see where the overdoses are happening. Law enforcement would be able to kind of see where they were happening. Public health could see where it was going on.
Neighborhood-wise, not actual address.
Neighborhood-wise, right, exactly, yes, thank you. If, you know, the Hollywood heroin that was out west, same idea, right? They had a bad batch of heroin, and it was really devastating to those communities. If that happened here, again, you'd be able to see kind of where it's developing, where it's going. You kind of see as it spreads out. And it's really a great recap for the last 72 hours. I know people's role in opiate, you know, the opiate epidemic kind of vary from what position you're in. You know, if you come in on a Monday morning and you look at the app or you look at the website and there were 2 opiate overdoses over the weekend, okay, maybe you go on your normal duties. If you walk in and there were 15 over the weekend, you know, maybe you change up your day and you try to do your role a little bit earlier in the day based on the volume of what's happening now, okay? And it just kind of speeds up that window when we can tell you what's going on. Instead of having to wait for the month, you'll be able to get it in live time as we go forward, okay?
Before you go on, hitting on that topic real quick, Council Belanger, this is something that I think maybe we can put on your task list is, this is a great product. We're using it here internally. We've given some reporting, but the logins we haven't done yet for the chiefs, for the superintendent, for the public health. We've talked about the new public health coordinator, Karen, even the superintendent of schools. You know, we have this is ready to go. These triggers are ready to go in, but we should talk to the city manager to make sure when it's appropriate to give these logins. So let's get this thing.
That's a great point, Chris. Thank you for mentioning. I will give that task to the manager and the prospective superintendents to decide who is going to have access to that
Because
information.
we're ready to
Ready,
roll with
then
this.
let's
Yeah.
use it, absolutely.
Okay,
That's a
sorry.
great point. Thank you.
One of the other thoughts we had that could help the city was the needle pickups. If you go to the page, needle pickup map, every time somebody calls 911 or calls the 3200 number for a needle pickup, we'll go head over, pick it up. We document where we're finding the needles. And again, it's kind of indicative of where the heroin overdoses are happening. It's and it's also a public health risk. So again, the city, via the health department, can have access to that so they can see where all the needle pickups have been. All right, again, try to just increase situational awareness a little bit better. At the next page, you can see there's one for the schools. So we kind of thought, is there a way that the school department supervisor or nurses may want to know every time an ambulance goes to one of their schools? And this is just a tool to help them, again, their situational awareness of what's going on. Instead of having to depend on a nurse to send an email to them, they would just get this automated notification.
Again, this is automated, which is great. It's real time, which is great. The best thing about it, that, again, if you're the superintendent of schools, you're coming in on a Monday, you can see, you're not waiting a quarter to see what happened. You're getting this now. So the report that's shown on this PowerPoint is just something that they can react to, will be real time. It's just something that, you know, to put it in the hands of the superintendent would be fantastic. So we need to get that moving.
So there's a supportive role that we're playing with the Project CARE that the superintendent's going to talk about. We're kind of in the background trying to help support that.
Yep.
This product is really fully customizable, so if Ebola comes back and it becomes a real concern, you know, we can develop, they actually have a trigger for that we could deploy, again, in public health awareness.
Yeah, it's not just one-dimensional here.
Correct,
It's
yes,
many
sir.
different
Yep.
health crises.
The Zika
yeah.
virus, if that comes up here, again, we're able to do it, and as the public health and the public safety needs in the community change and grow, this product can do it along with us. So right now, we're dealing with the opiates. You know, 3 or 4 years from now, there may be a different subcommittee trying to focus on something different, and this really gives us a platform that we can build off to try to, you know, help our public safety and our public health partners.
All right, John, thank you. Great presentation. Thank you very much. Council Rook.
Thank you, Mr. Chairman. This is the second time I've seen this rollout, John, and it's just as impressive this time was the first time. This is also something that Tree did not have to do, but out of your own expense, you've done this, and I think it's going to be a great help to both the schools and to both fire and police. The one quick question I do have is, when someone does overdose and passes away, usually there's a time period of waiting between the cause of death to know why that person did pass. With this here, when you go to a call, or on fire or police go to a call, and opioids or the reason for the overdose would be heroin, right? Well, how are you able to acknowledge that right away with the app, but then it's 6 or 8 months down the line before the state can tell us why the person passed?
So with fatal overdoses, unless it's really known to us at the time that it was a heroin overdose, it does not. So a situation, if let's say we go find somebody who's recently deceased and there's no real clear indication that it was that, it would not notify you of that. We don't want to complicate law enforcement by conjecturing in a patient care report why they died. That's the one limitation we have in the opiate overdose world is really the fatalities.
Thank you.
Great, Council. Thank you. Councilor Mercia.
Thank you very much, Mr. Chairman. Great presentation, Mr. Kelly. I'm very, very pleased because in the city of Lowell, we're very, very rich in the partnership that we have between all the entities. And this program is good where we need the data. And we have this superintendent of police and the superintendent of the fire department. We have good partners here. And I know that you can customize this program, which is very, very important. For example, you can tell that if there's an overdose with fentanyl, which is very deadly, and it's a bad batch, you can actually alert if it's near the borders, other communities, as to look out for this. It's happening in Lowell in this area, and it's probably coming your way. So that's a good mix to talk about. But when you customize, do you have an app that can single out that these people, this guy or this woman was a veteran? Do you have that available yet? Because that's very important to our district attorney, Marion Ryan, when we had a presentation done in our opioid monthly meeting, and she talked about Bedford VA Hospital, and there's programs available, but we don't know if these people that are we have post-traumatic stress disorder. We have people that are on drugs because they've seen a lot in the war, in the service. And so we want to help the veterans as well. So do you have a way to single out that this person that we picked up was a veteran?
So the program could do that, right? We could put
It
what we
could
call
do
an
that.
intervention, and we could have an intervention be a veteran. It gets a little, we'd have to find out they were a veteran. Somehow they would have to tell us that.
That's the tough part.
So you can't ask that. They have to voluntarily tell you that.
That could go either way. I
Yeah.
think. And also what we have to do on our patient care reports, we have to put somewhere that we can put in there, either a box saying veteran or something in our PCR report, so we can mine that data to find that they were a veteran as well. But
Right, so you're right. We could ask, are you a veteran? If they selected yes in the interventions, we could select veteran and then design a trigger that if veteran is selected, then fire the trigger, if you will.
This program's available
Notification
at,
of that to anybody else, though, that's the part we'd have to talk to with HIPAA concerns. Just because they're a veteran, that doesn't necessarily give us the authority to pass the entire patient care report on to somebody else.
now, the Project
That's
Care
what we have to
thing
figure it out.
that the district attorney is doing, the Project Care with the child present.
Yes.
And that, when a child is involved in an overdose like this, you flush your HIPAA out the window. Everything's off. You know, with the
That's
veterans, it's a little bit more.
important.
yeah.
That's a very good, important statement, because if you see two people, like quite recently, that did an overdose in a car and they had a child in the back seat of the car, we don't think about the victim being the child. We think about, this person overdosed, and we never think about the person that died in the house for a day, and the children thought she was sleeping, and actually she died of an overdose. What trauma did those children go through? They're the survivors that have to deal with this. So Project Care is a very important aspect to this, and you can monitor that.
And HIPAA goes out the window with that.
There you go. And HIPAA should go out the window when you're asking, are you a veteran? Because there's help available that they probably don't realize about. So this is very important, and I wanted to bring up.
We'd be more than happy to meet with the VA or any of the veterans groups and our HIPAA attorneys, and we can, if there's a way to figure it out, we certainly will.
Sure, because a veteran is a very important part of this community. They went and they served their time. Oh, are you a veteran? Oh, see, I know. So thank you very much. This is good. Everybody's on the same page. A very deadly prospect that's in front of us. And the strange thing is, if this were an outbreak of Ebola or meningitis or whatever, we'd all be on top of this. And at one time, we weren't with the opioid crisis. Today we are, so I'm very happy, because this is a very serious. I think as of January, there's like 47 overdose deaths in Lowell alone. I don't know if it's increasing, but it's a concern for our community. Thank you.
No, some great points, Council Mercy, especially on the veteran status. That was an outstanding point to make, and I can't agree with you more on this crisis is awful due to the fact that it's not a contagious disease. It doesn't receive the respect that it should. And it's a shame, because there's people dying out here in our very streets, and it's a shame. Council Rook.
Thank you, Mr. Chairman. Just one further question, I guess, could be for you, John, or for the superintendent or the chief. If the police department's the first one to show up or administer the Narcan, or the fire department's the first one to administer the Narcan, do you guys still get that info and put it into the system?
Generally, yes. So last month, we showed fire gave Narcan 17 times in our documentation. So we do note who did it.
Okay, and this, Chief Owen, so every time that the fire department administers Narcan to a potential overdose, does Trinity always shows up, and are they given the information as far as, the fire might get there first, but then the Trinity takes over as far as the care afterwards, or taking the person to the hospital maybe?
Sure, most of our firefighters are EMTs, and if we get on scene first, we'll start patient care and then transfer care over to Trinity, along with any information, any relevant information along with the call. And also our company officers will write a report to our EMS coordinator, Lieutenant Reddy, anytime Narcan is administered by the fire department, so we keep a record of that as well.
All right, thank you. Superintendent, same thing as for the police department as well?
Yes, that's correct.
All right, thank you. Thanks, Mr. Chairman.
That's great, thank you. Else sworn in introduced Councilors John Leahy and Councilors Bill Samaras are on hand to join us. So, John, back to you. Do you have any, without handing out, can you give us an overview on the month of, I know we're just a few days into April, how statistics in March, may I ask? I know you've been given pretty much a monthly presentation to the subcommittee and/or the council. And I'm just wondering how,
Yeah, so Chris will hand those out. So March was, if you go to page 3, for the the categorized report that we always talk about takes out all the false positives and we read them and everything. We were about 2 a day. If you go to that page, I think the volume has rebounded. We had that, if you remember, in December, the volume fell quite a bit. We had a lot less opiate overdoses that month, but it's come back to what unfortunately has become kind of the norm levels, if you will.
Which page are you looking at?
Page 3, the last page in it. What we've started to do is read the patient care reports from 2014. So we've done all of 2015, we're doing 16 as we go, and we've gone back to try to read 14. So if you go to page 3, which says month-to-month review, if you look at March of 2014, there were 24 opiate overdoses in that month. There were 46 last year and 57 this month. So you can see that you've almost doubled, or actually more than doubled, in 25-month span. But the really kind of the scary part is that priority 1 category over a little bit. So these are the patients that are really, unless the fire department, the police department, or Trinity, or some other bystander with Narcan is there to help, these people are going to die. Then, right then. These are the sickest of the sick patients. In 2014, in March, there were 12 of those instances. Last year, there were 20. Last month, there were 32. So the frequency is up a lot, but it's the severity. You know, anecdotally reading the reports from 2014, it would take 1 dose of Narcan to revive somebody. We've had the Narcan on the ambulances since 2011. It would take 1 dose generally to revive somebody. Now we're reading the reports, and fire's getting there first, and they're giving a dose. We're getting there and giving a dose. The paramedics are getting there a dose, and we're giving 3, 4 doses to revive people. So the frequency's up a lot. The severity of the patients is up dramatically, and the amount of Narcan to revive people is enormous.
There was one instance where I believe it was 10.
They get 10 milligrams of Narcan to bring someone back.
Wow. Now, John, what do you attribute that to? Why did one administering Narcans once used to work, and now why is it so many?
I believe it's the fentanyl. The mix of the
Councilman
heroin
Mercier
is...
mentioned, yeah. Wow. I mean, the trend changes in the drug, it seems. It just keeps getting more synthetic, more stronger, and by the time we catch up to it, we focus on it, and then it's changed again. It's gotten even more potent or more lethal, and what a frustrating battle, unfortunately, isn't it? But you guys are doing an outstanding job, all of you, and first responders, police, fire, ambulance. You're doing all you can. You really are, and I commend you very highly for what you do. But it's never ending. It's evolving, and I tell you. But anybody else got anything to add before we? Councilor Mercier?
When you go back to the same person, you can go back as many as maybe 4 or 5 times in a day. Could it be possible?
Yes, it's possible.
Do you indicate that on any report? This is the 3rd time we've been to the same person, or this is the 4th or 5th time? Do you indicate that anywhere?
Not on the individual report. We're working with First Watch to develop a repeat address trigger, so that if we go to a specific address for an opiate overdose, a combination of if statements, if we go for an opiate overdose and we've gone to this address X number of times in the last 30 days, that it would give us some notification of that. They're still trying to develop that one.
I know we have talked about it in the past. It's not as common as you think.
Oh, it's not as common.
Not as common as you think.
Oh, that's a good thing.
No.
Oh, I thought it might have been common. Because I thought if there was a law put in effect, I know it's probably unconstitutional, anytime we go to someone for the 4th time or 5th time in a day, we should be able to throw something out the HIPAA or whatever out the window and get help for this person before because they're ready to die. They're going to die. I don't know. Maybe that's unconstitutional. I don't know. And plus, it's frustrating for all the public servants, safety officials that have to go out and I hate to say cater, but they're time-consuming for this one person all this time clearly shows to me that they need some sort of help without their, it's just like years ago when we used to arrest a drunk person for their own protection, then I think this is the same thing in my eyes, that I don't want to see you die. We're gonna think for you because evidently you don't want to think for yourself. So I know it's probably against the law, but something should kick in at when we're utilizing all our safety forces and putting the rest of the public in jeopardy when we're doing all this. But I mean, I know I want to save lives, but it's the ACLU will come right down on us. I can hear it now, but anyway, sorry, that's
No,
my
it's a good
comment.
point, Counselor. It's a good point. It's unfortunate, Governor Baker's his legislation for 72 hours, if an individual was found a danger to themselves and the community, they were going to go involuntarily to a treatment facility, not a jail cell now. And,
No, I don't mean a jail.
I know
don't mean
that. I know that. Yeah, I know what you're saying. But unfortunately, there was a few it did not go through. But part of the reason is there's not enough beds, and so that was part of the
Yeah,
issue.
probably.
And it's very frustrating. It's very that because that's what a bottleneck is: beds and detoxes and treatment facilities. So go to Terry Downs.
Thank you, Mr. Chairman. I just want to bring up one point, which is that it seems to be an aspect of the increasing use of Narcan. One of the good things is obviously it's saving a lot of lives. One of the bad things is apparently a lot of people don't realize you really are buying time to get you to an emergency room and let the doctors take care of you properly. You shouldn't just be taking Narcan and walking away, and we all know that, but it's hard to get that message out. Another aspect of that seems to be developing is apparently there's a sense among the emergency providers in the region that with, and maybe some of the folks who actually do this sort of work can comment on this, that with more Narcan easily available in pharmacies and generally in the community, which is a good thing, there seems to be a sense that people are overdosing, being revived by friends or relatives who are there with Narcan. That's not being reported to EMS or to the police department or to the fire department. They never know about it, and there's nobody there to tell the people who've been revived, you really do need to get to the hospital because all you've bought is 30 to 90 minutes of safety. And if the Narcan wears off and the drugs are still in your system, you could still die. So that seems to be a problem that's developing, and maybe some of the folks who are out in the street might have a better sense of that. But that's a concern that I wanted to bring up. And that maybe is something that we need to reinforce in the educational side of it, especially in the schools, because the kids can help get the messages home to the families. It's a great tool, but it's not a panacea. It doesn't cure it. It just buys you time in an emergency. Thank you, Mr. Chairman.
It's a very good point, Terry. Thank you, Mr. Downs.
So would it be possible that the packaging that this Narcan comes in has an insert that says, after you take this medicine, you should go to the hospital or whatever? You buy a pack of cigarettes, it said the Surgeon General warned you that this could be hazardous to your health. Wouldn't they have such a thing? I know it probably does. They should put it in a packaging of a plastic or something, or cellophane, and inside should be a little paper that says, after administering this product, you should go to the hospital. You're not out of danger completely. So there should be a warning somehow inside of in a packaging thing. I don't know how the Narcan comes if you wanted to go get it somewhere. Is it in cellophane or whatever? It's in a box. Well, in that box should be an insert of a paper that tells you that reminds you that you should. Oh, we have a demonstration here. So that box, on that box should say, after you administer this, you should go to a hospital, because if you don't, or something to that effect, to warn them on that box. Just like they're warning you on a pack of cigarettes that smoking that could be hazardous to your health, at least they have a chance to know that, so that they can't say, gee, he didn't go to the hospital and now he's dead and I didn't know that. Unless you can read, and put it in other languages or whatever on that box. I don't think it says that on that box, does it? Maybe it should.
No, I agree, Counsel, it's a good point, and Terry Downs makes an excellent point. Those who administer Narcan at home to a family member, that goes unregistered, so what's the number there? We have no idea. That's another great point, Terry. So, Counsel Leahy, to you.
Thank you. I broke the microphone. My question is just a follow-up on, so how are we paying for all the knock?
Yes, Counselor, we received a grant, I think it was $50,000 from the state EOPS to supply Narcan to both police and fire.
Is that running low, or how are we running on funds?
No, I think we'll have sufficient funds to make sure that we're completely outfitted for all of our apparatus and vehicles for the next year. And actually, there's extra money incorporated in that for some training and for some other support equipment that both the police and fire can use.
Okay. And I didn't know what Mr. Downs brought up. So if you administer Narcan, you're still not out of the woods?
Right. Narcan essentially buys you time, depending on all the circumstances, the person's age, their general medical condition, their height, their weight, and how much of the drug they took. As I understand it, it'll buy you anywhere between 30 and 90 minutes, where it essentially neutralizes the effectiveness of the drug. But then the Narcan wears off, and the drug can come flooding back into your brain. And so if you don't get medical help in that period of time, you're right back into the overdose. And apparently, there are a number of cases where people will be administered the Narcan, they'll wake up, they'll be angry at you because you ruined their high, and they run out and get more drugs, and now they've got a double dose of drugs in their system. And then eventually, of course, the Narcan wears off, and now they've got a double dose going, and they die from that. So it's a great tool, but it's an emergency tool to buy you time. It's a wonderful tool, but that's all it is. It buys you time to get to an emergency room.
Okay, and just one other follow-up. So if you have, how do you get that for your own use? If you've talked to your physician, you say you have a situation in your family, and they'll write your prescription to have it in your house?
So, you don't even need a prescription anymore. CVS has it. You can walk in,
You
it's a
just go in
20,
and
you can
get
buy
it?
it for $20. Lowell House is, I think, giving away free. Project Hope gives away free at their meetings. They do the training it's at Saints on Wednesdays and Tewksbury on Thursdays, I believe. There's a lot out in the community.
Okay. All right, thank you.
Thank you, Counselor. Chief Winwood.
An important point is if someone does overdose on an opiate and stops breathing, it's very important to call 911 and get medical help there immediately, because a lot of these people need rescue breathing. Sometimes it takes a little bit of time for the Narcan to work, and they may need rescue breathing to stay alive until the Narcan kicks in. So it is very important to get medical help on the scene right away, and then to get follow-up at the hospital.
Thank you. Thank you for that information, Chief. Okay, any more input on First Watch program before we go over to Project Co-op? Okay, with that being said, Chief Taylor, I'd like you to elaborate a little bit on Project Co-op.
Thank you, Counselor. And first, let me make a couple of comments about the opiate epidemic in general. As Trinity's numbers clearly indicate, March has been a frightening
Rough
and
month.
Deadly month
Yep.
for the city of Lowell. Currently, we have investigated what we believe to be a likely number of 23 or 24 opiate-related deaths in the city of Lowell so far this year. So that's on pace to significantly exceed last year's total of
So we're
47.
halfway to last year's total in 93 months.
That's right.
Wow.
So, you know, the situation we find ourselves in, not just Lowell, obviously, the entire region. Certainly, Lowell seems to be one of the areas that is significantly impacted by it, though. This crisis continues to deepen, and it's quite candidly very frightening, you know. And I had a conversation with the district attorney this afternoon, and her numbers, likewise across the entire county. She used a similar, word to describe this past weekend as frightening, what she saw across the entire county. And Lowell obviously is the biggest component of the county. So that's the reality that we face. Last year, the numbers that the health department has for the city of Lowell, we have an operational number that we used for last year of 47 instances where we believe we investigated a sudden death that we believe is reasonably associated with an opiate overdose. Again, it takes a long time to get concrete toxicology results. The ME's office actually has a higher number that they supplied to the Lowell Health Department for last year, and they still have many cases that are pending toxicology results. So again, sobering, frightening, deepening crisis that really shows no sign of abating, even in light of everybody's best efforts here. So what we did was we came up with a couple of programs that we think can potentially help alleviate this issue. One of them is the co-op program in the city of Lowell. I'll give you a real brief idea why we came up with this. This is, we can't take credit for organizing this, but Fred Ryan, who's the police chief in Arlington, and people that work in that general area, and I think they have a similar program in Boston and a couple other communities, certainly not on the scale that we're going to impose it here in the city of Lowell. We're a much bigger municipality than some of the other places like Arlington. The idea is to be proactive and do outreach into the community to people that have recently overdosed, and also people in the homeless and veteran community in the city. And so what this is designed to, it stands for a Community Opioid Outreach Program. And it's a partnership between the Lowell Police Department, the City of Lowell Health Department, and Lowell House, which is a substance abuse counseling program in the city. And increasingly, the fire department is going to come on as our partner on this too, to provide support in this. It's really an all-hands-on-deck type of situation. And the objective here is to identify these individuals that have recently overdosed. So within 24 to 48 hours, we will either internally get the information about people that have overdosed and in most cases been revived with Narcan. And if we don't have it, we'll get it in some capacity through our partners at Trinity. Then we've teamed up a police officer. This is Officer Kevin Garno, who is a tremendous asset to this city. He is the point person on this for the police department. He's teamed up with somebody that's a substance abuse case manager from Lowell House, and then also somebody from the Lowell Health Department that specializes in substance abuse treatment. They go out as a team. They try and find these individuals that have recently overdosed, and they do everything they possibly can to encourage them into treatment. And then a big component of this is also building relationships with treatment facilities and other resources in the entire general area. So Tewksbury State Hospital has several resources there for detox, Lowell House, there's Megan's House in Pawtuckaville. There's a multitude of different agencies and resources that we can try and channel people into to get them into recovery and try to start the process of beating this illness. And so that's really the objective behind it. They go out and do actually home visits. The police officer goes along with them. It's all designed, it's not enforcement geared, it's all designed to try and encourage people into treatment. That's really the objective here. And then they go into the homeless communities. I'll tell you a story. We had a situation in October where we had an overdose of a gentleman in an abandoned, like a railroad encampment where he was living in a homeless situation. And, tragically, the person passed away, and he passed away alone, as most of them do, in really terrible conditions. And we found out through talking to some people that knew him that he was trying to get into treatment and that he was trying to get on Suboxone, which is a treatment for this disease. But he didn't make it. He didn't have his appointment in time. So we kind of took that information, and then coincidentally we found somebody in my staff actually got me a copy of his obituary. And what you find out is that this poor individual wasn't a nameless, faceless individual that died alone of an opiate overdose. You find out that a person was actually lived in a neighboring community, was a 28-year-old person, male. He lived if you read his obituary, you'd certainly come to the conclusion he had a loving, caring family that tried to help him. Unfortunately, they couldn't reach him. And he actually was a veteran. He served his country. So you put all that together, and then you get a better picture of how this is impacting this community and families, ripping people apart in the tragic toll that it's taking on individuals, families, and the community in general. And then you find out that we have to do more. And so really this is an effort to try and go out proactively and reach out to people and see if we can do everything we possibly can to encourage them to get into treatment. Because what's remarkable about that story is how unremarkable it is. That is what happens. And it's just another nameless, faceless person until you find out more information. So that's really an effort on our part, on the police department's part, with many of our partners, to see if we can, try to get more people into treatment. So.
Well, very good, Chief. That's certainly a very proactive program you've got there, and it works nicely with the First Watch having thanks to Trinity, having up-to-the-minute data there. Where you could see these individuals' names, and you see, over the course of 72 hours, you see the same name 2 or 3 times. You can go after that individual and, again, encourage treatment. You can't do much more than that, unfortunately, but you can't do much more than what you're doing, Chief, so I commend you highly. So anybody else have any input on this?
Officer Gano's here. If you have any questions of him, he's actually out there doing the hard work.
Yep.
He's, tremendous. I can't say enough about Officer Gano and the other 2 individuals that work with them in this program.
Okay, Officer Gano, can you give us a little input on this? At this point, how the program's going? You're out there in the trenches. If you can give the subcommittee and the folks at home a little update, it'd be great.
Yes, Council. The program's about 3 weeks since we implemented the start of it. Since then, we've visited about 20 individuals. We had one that overdosed 4 times in a 24-hour period. However, it would be different addresses, which wouldn't address the mapping issue. We've had some success. We've gotten some people on Vivitrol, one on Suboxone. We've also had some failures where they've relapsed, and we've reached out to them again. On top of that, we're also doing the homeless liaison, which is the outreach portion to the encampment, which is what we already started from the beginning, such as the education on the Narcan. There's also temperatures. It basically has to be at room temperature. So all these encampments, if they leave it in the tent and it freezes, the Narcan's not going to be good when they need it. So we also educate how to use it out in the encampment so that they are instructed, and what the half-life is, that it does wear off and you can relapse into another overdose. But that's where we're at now. We're keeping track of all the data, and I'm pretty sure we could put a report together for the council.
That's great, Officer. Great job. Great job. 20 individuals in just a few weeks. That's outstanding. Thank you. Thank you for what you're doing. Anybody else have anything to say?
No, I can tell you, Councilor, about one other initiative that we've undertaken in conjunction with the District Attorney's Office, if you'd like. That's the CARE project.
Yeah.
That's the Child Assessment and Response Evaluation. That essentially what that involves is, Councilor Mercia hit on this a little bit earlier, where we go to overdoses, and very unfortunately sometimes there's an indication that there's a child present. Either physically we see the child, or there could be car seats available, or whatever it might be. And so the district attorney, this is an initiative that she really has taken up, and I think she should be commended. And I think what the police department in Lowell is proud of is when she developed this program, she brought it to us first to implement, because she knows she has a willing partner here with the men and women in this organization and the city in general. So we've instituted a protocol so that when our offices and the fire department also can take advantage of this, they've been trained on it. They go to a situation that's an overdose. If there's any indication at all that there's a child present or could be present, what they do is they call the mental health coordinator. It's the Mental Health Association of Greater Lowell is the partner with this. We have a hotline number that we call. They do a triage over the phone to get the pertinent information. They follow up the very next day with that family and that individual, and they take the lead to notify the schools, the medical community, so that those children that could be potentially involved in this get the resources and the help that they need, so that the theory is, down the line, they don't become the next victim of this, 5-10 years down the line. And so that's the objective on this. It's another great initiative.
Absolutely, and Lowell's the pilot program, Chief,
That's right.
correct?
That's right. She intends, the district attorney
Yeah.
intends to roll this out countywide.
That's outstanding, and we like to commend DA Marion Ryan on her hard work and her help. She's been very helpful to us. Thank you. Councilor Rourke.
Thanks, Chairman. Just a quick question. Is DCF notified by the police department on these cases?
We also would notify DCF independently, but the district attorney has met with DCF. They are completely on board with this, so they'll share information back and forth. They think this is a good prototype to move across the rest of the state.
Thank you.
Thank you. Chief Winwood, to you.
We've also trained all the firefighters to look for signs for children in a house in a case of an overdose. We're giving them a card with indicators that there might be a child in the house, and we would also notify DCF along with our partners with police and Trinity.
Very good, Chief. That's great. Thank you. Anybody else got anything to add?
No, I think it's a good partnership. Keep it going because we're trying to lick this epidemic and save lives. And I think the number one problem is we don't have enough beds available. We're doing the outreach and stuff, but the outreach is good, but if we don't have the other component as in beds, we're licked. And I think that Bill Garr and the House of Hope, Lowell House, they have a plan coming on board. We're going to bring that before our housing subcommittee. I have a motion on the agenda this evening to ask for information about that, refer it to our housing subcommittee, of which I'm the chair, and we're going to sit down and have a discussion like this televised about his proposal. So Megan House and all these places, they're beautiful. We need more. It's a shame, It's on the idea that substations were coming up and churches were closing. So we have another turnaround, and we need more beds to put more people in to save more lives. That's why we have this drug court program at the Lowell District Courthouse. I didn't do it, but the partnership saved 6 lives that graduated. They're gonna be, it's amazing. And if we can do 6 at a time and then multiply it, and it's a grueling program. I hear about it, I know about it. I attended the graduation. Where I work at the sheriff's office, we deal with these people. I give them encouragement every time I can. It's not easy to beat an addiction. I was a smoker for many, many years. That's a drug. That's a bad habit. My son was a person that drank and was very, very mean. Every time he drank and caused trouble, he went to jail. I'm not proud of that. But I said to him, listen, you have a son and you have a girlfriend. You need to get off this alcohol. You can't do it. You're a bad person. You need to stop. If you stop your drinking, I will stop smoking. October 25th will be 12 years. He hasn't had a drink, and I haven't had a cigarette because I loved him that much to give up something that I thought would be, I couldn't tell him to give up something if I didn't. So we did together. He's got a lot to show for it. He has 3 sons. He married that girl. His children go to Central Catholic. I'm so darn proud of him. So I know that I had a habit and I beat it. And I encourage people that come in our center and are trying to do the right thing. And I think encouragement is very important. And I tell them this story. And if you want to, you can do it. I can't make you do it. You've got to realize it on your own. So this is a good story, and I want other people to succeed too. So,
Thank you very much, and I will say, I appreciate the city council and the members here keeping this in the forefront. We need to do that as community leaders to make sure everybody understands the scope of this issue and how bad it is. Because without question, this is the public safety and the public health issue of our time. There's no question about it. This is absolutely terrible.
I agree, Chief. And before we adjourn, I want to thank Trinity for the data again that they provided this evening. And the numbers are not good, ladies and gentlemen. I mean, the first 90 days here in the city of Lowell, The numbers are up dramatically, if you will. It's very discouraging, but the city of Lowell will keep working hard. And I know all of you, with your efforts, we will get progress. At some point, this will turn around. So I want to commend you for all your hard work, what you're doing, and we just got to keep our chin up and keep fighting, ladies and gentlemen. So thank you very much for all you do, and thank you for attending. Motion to adjourn.
Motion adjourned.
Meeting adjourned.